So I would like to, we're going straight into our final panel right now. So after thanking Karen quickly, I want to ask all of our panelists to head on up to the stage while I introduce them. This is a great group to focus and reflect on what we've discussed this morning, and especially where to go from here. So the topic is what's needed from policymakers, technology developers, providers, and I would add, especially based on the discussion today, consumers and support for consumers to get to high-value health care. This is health IT as a means to an end. As Karen and others have emphasized, it's about moving from the focus on stage 1 and stage 2 on the EHR and health IT capabilities to the actual results, and this fits very well with what we've heard from our other speakers this morning. So we've got a great group to discuss this topic. Simone Karp is the co-founder and chief business officer for CE City, which has implemented a range of clinical registries and other decision support systems using increasingly sophisticated electronic data, I think proving that some of this can be done now, despite all of the challenges that we've talked about. Mohit Kaushal, I am not seeing on the stage quite yet, but is coming right up. Right, so this is, again, just right on cue. This is what we like about perfect timing from these Silicon Valley guys. Mo is a partner at Aberdare Ventures and also a visiting scholar here at Brookings. Mo has some history in government with the FCC and on promoting health IT and broadband and other issues that we've written about, and is very much involved in some of the newer kinds of companies that are bringing health information out to consumers, as you heard about earlier today. Mark Probst is the Chief Information Officer and Vice President at Intermountain Healthcare, which has been a leading organization in terms of the adoption of electronic health records, other supporting systems using electronic data interchange to support consumers and patients in their healthcare system, and thinking about where the whole country can go and learn from those experiences. And Robert Waugh really has two hats. I think you're mainly wearing your hat as the president of the American Medical Association today, right? That's sort of the official. We'll push on the other one too. Don't worry. As president of the American Medical Association, also as the chief medical officer of Computer Sciences Corporation, which, is you all know, is very much involved in supporting the move to more effective electronic health care. So we mainly want to focus now on what happens next, or what should happen next. You got a perspective on where we are from Karen and some general directions going forward, but really want to focus on how to make more rapid progress towards the effective use of health IT. And Robert, maybe we could start with you. I think Karen gave you a nod during her comments about when I raised this issue of usability and ease of use for clinicians. I know you all at AMA have done a lot of work on this, not just what the problem is, but what are some constructive directions to address it. Maybe you could talk a little bit about that to start us off.
Sure, thanks Mark, and appreciate the opportunity to be here at Brookings, and it's a great group, and it's been a great morning already. One of the things that, at the American Medical Association, we just some boundaries around it. We have three major goals that we're trying to seek in the next 5 years. One is to improve health outcomes for our patients. One is to improve physician satisfaction and practice sustainability for our physicians. And finally, the last one is to improve medical education for the future doctors. So in the area of professional satisfaction, what we did about 2 years ago was teamed with the RAND Corporation to go out and survey physician practices to find what are the satisfiers and what are the dissatisfiers for them out there. And high on the list that came back from that RAND survey was electronic records. Nobody wanted to get rid of their electronic record, but they wanted it to work better. And so we dug a little deeper on that, put together a work group of health IT experts and practicing physicians, and convened it under the AMA umbrella. And last fall, I think in September, we reported out sort of the 8 topics or 8 areas of focus that we think electronic records need to improve to be more useful for the practicing physician. And when I say that, I think it's important, and Karen touched on this, and I'm glad she did, it's important to remember that we're not talking about technology here. We're talking about improving care for our patients. And Peter, I know, has been very active in trying to push the clinical perspective on this. And as physicians, I think it's always important for us to restate that that the reason why we're interested in technology is it can serve as a way to improve the care of our patients. And it can also serve as a way to get in the way of taking better care of our patients. So that's one of the concerns we had. So that paper we presented in September had 8 major points. And I'm not sure I can from memory repeat all 8, but there were things in it that Karen talked about and others this morning have talked about. We're seeking data liquidity, so information flows more like water and less like bricks. We want to see more coordination of care supported. We want to make sure team-based care is supported with the tool. We want to make sure that we have more modularity of functionality, that we can drop it in as needed as opposed to replace the entire system. We want to see more physician input into the future development of the tools and not just a technical perspective voiced in the software development process. So these are nothing groundbreaking there, but we think it's important that as physicians we put forward those issues about what we want to see in making the electronic record more of a tool that can help us take better care of our patients. So I think that's been, hopefully helpful. I was glad. I think Karen was also referencing the time in the prior administration when the first national coordinator, David has left now, I guess, but having served as the first deputy national coordinator and helping set up the office in 2005, I think she's also saying that we had some good ideas back then. When I said we had no money and big ideas, and then big money showed up in 2009. So I think that's always a part of it as well. So I think the other part that she was referencing is the AMA and physicians have been very vocal about our concerns about the Meaningful Use Program. Obviously, again, we all agreed to the high goals that Meaningful Use was seeking to do, which is, again, improve care using technology. Not easy to, everyone would agree to that. We all want that. But some of the mechanics and how that got done have become cumbersome for physicians in practice. There's 125 measures that now have to be complied with 100% to qualify for meaningful use, or you fail. We're concerned about that. And we've also asked for what I think I heard Karen say was perhaps it's an opportune time before going into the next phase of meaningful use to review, are we getting to our ultimate goal that we all want, which is can we use technology to help us improve taking care of our patients? So we've been very vocal about that. And I guess the final thing is, again, touching on what Karen brought up was the meaningful use is just one part of a bigger picture of what we're referring to as the regulatory tsunami that's hitting physicians. There's all these programs, meaningful use, e-prescribing, PQRS, physician quality reporting system, now the value-based modifier. All of these are coming at physicians at the same time, and we're concerned that each individual one seems okay in the individual sense, but if you take them as a whole, they're a big problem for practicing physicians today. And we're concerned about the potential of 13% decrease in physician payment from Medicare because of all these systems combined, but more importantly, of the regulatory and administrative burden that they're placing on physicians. We are hopeful about the words harmonization from CMS about reporting, because our physicians are saying that they're having to report multiple times basically the same information in slightly different formats. So again, we're hoping there'll be technology that'll allow them to report once and use it many times at CMS rather than report it multiple times, basically the same information. So hopefully that's a
Robert, that's a great overview, and I think the physicians, the diverse range of physicians you're representing, is really good to hear a summary of what some of the concerns are. I want to go to a different part of the community of practice with Intermountain, Mark. So maybe talk with you about some of the implications of how you all use health IT and what the consequences of that or the lessons from that may be for next steps on some of the federal policies that Robert has described. I think a brief summary, Robert, might be for electronic records for clinicians now. Can't live with them, can't live without them, and still, while they're doing some useful things, there still is a lot of burden there, and not as much as you'd like to see in terms of clear help in improving care for patients and maybe reducing administrative burdens on and creating some efficiencies for clinicians. Mark, what's your sense from where you practice first and then looking out to the broader world about how to make some progress on the challenges that Robert's identified?
So Intermountain Healthcare's had some advantages. Back when Homer Warner, the gentleman or the physician that invented HELP, our first electronic medical record system, which we think is maybe the first electronic medical record system anywhere. Somebody in Vermont thinks they invented one maybe a little earlier. We're pretty sure Homer did it. But when he did it and developed it, he based it all on standards. And he based it on standard data. And this data was going to be computable and usable. He didn't build a record system. He wasn't trying to get a CCDA to anybody. He was trying to take data and say, can we use data to help improve care? He's a cardiologist, so we have pictures of him running up and down the stairs with all this computer equipment on his back. And as you can imagine, in the 70s, that's like carrying an AS400 or something around on your back. But he was gathering data, and he was able to prove that through having discrete data and by assisting a physician in the practice of care, you could save lives. You could do it much, much better. And he showed that over and over again. And we have many protocols that show we have been able to save lots and lots of lives. I mean, it goes back to the premise that the mind, the human mind, really can only compute about 7 to 9 items and come up with a consistent and correct diagnosis. Well, today, a clinical decision is probably in the hundreds. I mean, back when I used to talk about this when I was working with Farzad, it was in the 70s. But there's so much more data now that how can you expect a clinician to make the right decision every time? That was Homer's premise. And so all along the way, we have developed systems that were based on standards and data that can be computed and then data that could help the clinician to do their job. So in our insulated system, and we're all in Utah, one little hospital up in Idaho, but we're pretty insulated, we have a standard. And we're able to manage within that standard, and we have had tremendous results. The care is very high at Intermountain Healthcare. You can look at the articles. And we are consistently the lowest cost provider of healthcare in the country from a per capita perspective. So there's some good things that can absolutely be done with technology. So when you ask me to extend that nationally or beyond Intermountain Healthcare, I mean, it goes back to the same thing I always talk about. It is standards. And we've heard that word. I was on the original policy committee meeting, so when we brought the very first VACA together in policy committee with David Blumenthal, we talked about meaningful use. And if the word standard was used 3 times in that first meeting, I'd be pretty surprised, and I probably said it twice. It wasn't the term, right? It was functionality. What are we going to bring in over time? And I'm not blaming anyone. That wasn't a lack of foresight. In fact, one of the more visionary people we had, it was about the 3rd meeting, is when we brought Bill Stead in from Vanderbilt, and he gave a very good presentation on data liquidity and how important that would be. And if we wanted meaningful use to be successful, we should pay attention to that. And that stuck with me because I think today we're seeing the outcome of that discussion and maybe a lack of emphasis on standards and the things that we could put in place so that these systems would truly interoperate. So I think at Intermountain Healthcare, we've been successful. We've had standards. We have data across our whole longitude of patients. We're able to bring information in. We're able to do decision support. We're able to help our clinicians. We have a lot of work, I think, to do on a national basis to get to that same level of value. But it's possible. And I guess my last thing, I have very much enjoyed what Karen said, and I think we're on the right path. I would just suggest it's too slow. Every year we waste getting these standards in place and getting this interoperability to happen, we're costing probably hundreds of thousands of lives, at least tens of thousands of lives, and clearly billions and billions of dollars. So I think it should be much more of a priority in discussion. It's a big discussion. It should be a priority to be in action.
That's actually a good segue to what I wanted to ask Simone about. So you all are working with a lot of healthcare providers who are not in an Intermountain system, and I know a lot of the efforts around building clinical registries and the related support systems have required some very hard work around getting access to needed data, which is the point of the standards that Mark was describing. From your perspective, where are we in terms of having standard enough data to support liquidity, to support really having impact on improving care and lowering costs for typical providers in practice today and the patients who get care from them?
Thank you, and thank you for having me today. I appreciate the invitation. So the opportunity is now. We're actually doing this work, and we can show many examples of it on a national level for thousands of physicians, and this year alone about 7.5 million patients. And the way that we're doing it is taking all of that work that you've done over the last decade in building this important foundation to have the data, to now take that data and make it into actionable information. And the way that we're doing it is through quality improvement registries. And many people are familiar with clinical data registries. What we're really talking about is a subset of clinical data registries. The AHRQ has actually defined quality improvement registries as the ability to take data and make it into actionable information. We need to get data from multiple sources, from the EHRs, from HIEs. I'm a pharmacist by training. We need to get it from the pharmacy, because if we really want to see the population who didn't get their flu vaccine, we need to be able to see the patients that were administered in a pharmacy, the patients that were administered in their local community clinics, as well as in the physician practices. And we need to do that in real time. We don't need to get data on who missed their flu vaccine in June when we've missed flu season. It's not going to be helpful for us. So we need that actionable information, and we need it now. And these quality improvement registries give us the opportunity to do that, not just for process measures, as we've heard this morning, and checking boxes, but on true outcomes measures. But being able to combine those outcome measures with process measures and financial measures to really look at that cost and quality equation. The work we're doing now with groups like the American College of Physicians, we collaborate on a registry called Genesis. We have over 15,000 providers in that registry from all types of providers, 1 and 2 physician practices, all the way up to very large integrated delivery networks. But the key is what you said a few moments ago. We have to reduce the burden on the healthcare team, but be able to help them have one data pipeline that they can plug into these quality improvement registries, but report out to multiple programs. And that's where we've shown our success. So we can take that one data pipeline in, calculate the data against those measures in real time, show those patient outliers to multiple healthcare teams, but then report that data to PQRS, to meaningful use, to specialized registries, as well as to professionalism requirements that we all have for things like maintenance of certification and maintenance of licensure.
And Mo, you as well are working with a number of new companies, new entities that are trying to use more liquid data. I think data liquidity is one of your big themes. Trying to use more of this kind of data pipeline to help get to better results, lower costs now. Maybe you could say a few words about where you see some of the opportunities in the short term for making progress on that, and whether your sense of the next steps for policy align with what we've heard from the rest of the panel.
Question. So I think just by context, I live in 2 very extreme worlds. So one is still thinking through what are the right policy levers to perpetuate this ecosystem. And in the other world, I sort of wear sneakers, wear a hoodie, hang out with these young entrepreneurial teams that I invest in and advise. And not all of them, but many of them are very techno-libertarian. So they think what happens here is completely irrelevant. I don't fully agree with that, but we have seen through history that stepwise changes in technology actually do disrupt existing ways of doing things. So when I think about how DC can perpetuate Silicon Valley and Boston, for me, I think the biggest lever is just building and creating markets. The more money that goes into creating business models that are prerequisited on data liquidity, the more talented people will jump in. I want these engineers not to be working on sort of the next generation of photo apps. I want them to focus on healthcare and education. And that is happening slowly. And maybe this is a religious debate, but I fundamentally believe that if we pay more for outcomes, so $1 trillion goes to sort of Medicare and Medicaid, the more of that is pushed towards outcomes, I fundamentally believe that data and technology is needed to enable that. So as that pie increases, one would imagine more and more people jump in, and we're seeing that. But it's still very early in this journey. I'd say I've been investing in this space for 5 years, and we now have exits, but we're still at the beginning of this, and it'll take time.
So I heard from a very strong statement. I saw a lot of nodding when you were talking about the move towards paying for outcomes and paying for results. That was a theme earlier today. So still seeing nodding that that's kind of the right direction for federal policy. And I'm going to have a follow-up for you about what does that mean for meaningful use payment incentives. Should they just be part of that overall shift to outcomes payment? What should happen in meaningful use phase 3? Do you want to?
Yeah, so I was thinking about this
we'll go down the line.
after the phone call. I think the debate is what should happen in parallel versus sequentially. If we were all sitting here and saying, look, here are the 20 business models or payment models that we know that work, then one could argue, well, meaningful use should be just wrapped into outcomes-based. I'm saying that's not the case. I think we still need to start capturing the data to still figure out what are the best payment models. So I fundamentally believe there has to be a lot of parallel work here. And then as we progress to meaningful use, we've talked about it before, so I don't want to go into it again. I think interoperability is a real interesting lever that we could apply to meaningful use.
And does that, just to push a little bit on this, and I do want to hear from all of you, and this is a big topic, I want to spend a few minutes on it, in terms of things going beyond just paying for results. I heard earlier from David Brailer, and I think to some extent from Farzad, about the desirability of having a person-level sort of package or information capacity, and maybe intermediaries who could help handle that. Is that something that meaningful use would actually pay for, like the actual results of getting the data together, which then could be used in these kinds of outcome-based systems? What is meaningful use phase 3 going to be if it's not just merging in with the outcome-based payments?
Great question. So I'd argue the interoperability stuff that is getting discussed is sort of superficial interoperability. It's not pure liquidity to the extent that we've talked about. And I'm not sure that policy is the biggest lever here. I think the biggest leverage point in US healthcare is the role of the consumer. As risk gets shifted to them, whole new business models are getting created. So I'm not fully convinced that meaningful use can be applied to the individual level in terms of making it. I think that's going to happen just by market dynamics anyway.
So meaningful use may not end up being that relevant, and actually they go along with what some of your entrepreneurs are telling you.
I think it's relevant provider to provider, but the provider to consumer stuff, I think bigger demand is going to be created by the risk shifting.
Mark?
As far as meaningful use goes, I mean, going to outcomes and value, I think that drives a lot of the markets that we're talking about, and would make a lot of value. Meaningful use 3, my belief on meaningful use at this point is we should claim victory. We've gotten these systems out there, they're in people's hands, and the government ought to take a step back, except for, and there's probably going to be disagreement amongst some of these, I do believe the government should be setting a set of basic standards so that we can get liquidity of data. And I don't mean that from the government being the policymaker. I mean that from the government being the leader to take the knowledgeable people and drive these standards in. Similar to the fact we drive down the right side of the road, or I was talking to Robert last night and he said there was an emperor in China long before there were trains that said this is how wide an axle is going to be, so that everything else could go from there. The size of the bridges, the size of the roads, everything else could flourish once a basic set of standards are in place. So if I were to say, claim victory on meaningful use, we've done a great job. I think we've done a great job getting digitized systems out into our nation. But now let's focus on some basic things that will allow interoperability to happen and will allow these markets to really flourish.
Okay, I do want to come back to what we mean by effective liquidity standards or interoperability standards, but let's stay with the focus on meaningful use phase 3 payments right now.
Well, it looks like we're going sequentially. Certainly I agree with Mark, this concept of declaring victory, that we've made a lot of progress in getting electronic records out there. We've spent literally billions of dollars on this. And we want to make sure, again, reviewing what the ultimate goal of the Meaningful Use program is to get tools out there to help us take better care of our patients. In many ways, we've done that. And so whether or not we need another phase like I said, we've all complained about this, the various measures that are process and not outcome and all that kind of stuff. So I don't have any more to add about that. I do want to comment on all this discussion about payment reform. So I had the opportunity to be with the Secretary when they announced what Karen talked about, was how they want to move the metric to 50% of the payments going to be outcome-based. And again, as a physician, I'm very biased in this area. I think it'd be better to move the needle towards talking about delivery reform and payment reform. And all I ever hear about is payment reform. And so I recognize that they're clearly intertwined together, but I'd like to hear a little more talk about delivery a little earlier and payment a little less. In my perfect world, the nirvana for a physician would be we'd craft the ideal way to deliver care to our patients that gets us the best outcome in the most cost-effective and cost-efficient way. And then we'd bring in the finance people to craft a payment system to make that delivery system work. But that's never the way it happens. We all tinker with the payment system, hoping to drive the delivery system in some way or shape or form. And sometimes we're right, and sometimes we're not. And we've all seen unexpected consequences of changing the payment system and getting something we didn't want out of the delivery system. So I just want the conversation to move a little bit more towards delivery on balance with payment.
And how critical is, and I do want to come back to stick with the payment changes too, but how critical is further steps on health IT to enabling the delivery form? And when you say you want more emphasis on delivery form, I take it behind that is a lot of frustration among physicians who see all these new payment systems coming in Medicare and elsewhere and don't feel like perhaps they've got the tools and support they need to really do well as they take on these new kinds of accountability.
Yeah, I think there's two places here. One is I clearly see foundationally health IT is a foundational element to get us to be able to reform our system. We've all made that comment, you can't reform the system when it stays on paper. I agree with that. So we had to move off the paper platform onto a digital platform. And then where we go with that digital platform, I hope, is network together this interoperability, this liquidity issue, because then we'll be able to analyze the information that we have digital now as opposed to paper in new and powerful ways that will lead to the improving care of our patients. So yeah, I'm absolutely in favor of all this. Along that road, how many administrative and regulatory steps physicians are burdened with, obviously we'd like to minimize that.
Right, Simone, is it time to declare victory on meaningful use such as it is and just shift the focus towards the payment reforms and practical interoperability steps that can help support delivery reforms to get there? Is that
From our experience from working with all types of providers across the country, we think that we really need some standards for some open APIs on distinctive data elements, because if we think about these outcome measures, I always simplify it, they're a numerator and a denominator. And who's in that denominator and who's falling outside that numerator. And in order for us to get to those elements, we need trusted, validated data. So we can't just develop a standard, we need to then be able to make sure that it's validated and that the data is then trusted by the healthcare professionals that then need to rely on that data. If we could do that, I think we could scale and stop reinventing the wheel over and over again.
Okay. So to pursue this emphasis that all of you have placed on interoperability, and I think that fits in, Simone, with your last comment too about the importance of having trusted data available to construct the measures that will matter in these payment reform systems. We've made some progress there. I think it's in some ways very much like meaningful use. Some progress, some notable successes in moving to outcome measures, but awful lot of gaps and questions about the validity and availability even of important measures. So let's focus a bit more on what we mean by interoperability to support these kinds of reforms. You all have talked about liquidity, you've talked about basic standards. What exactly does that mean? Are you seeing that in say, the recent interoperability roadmap from HHS? Is there a different place that you'd put the emphasis? I'm getting a real sense of emphasis on practical impact here that maybe feels like we're not quite there yet on policy. And I'm just wondering how we can help. What else can help us get there?
I can
yeah,
maybe
Simone,
take
do
a
you want to
stab.
start?
I think in the roadmap what we see is what Dr. Salvo just said as well, is these distinctive data elements. And that's what I think we need to really create what the IOM has also called that learning health system, to create those feedback loops. So I think we need those distinctive data elements. I think it's all aligned with the roadmap to then be able to calculate those measures across systems from multiple data sources.
Other thoughts on what interoperability and standards to support interoperability should mean?
I think the roadmap's pretty good. I think it's too long. I don't think it's...
too long in terms of detail or too long in terms of time?
In terms of time. And it's going to take a level of detail, but it doesn't have a level of urgency that I would like to see because of what I said earlier. I mean, I do think we're really talking lives and many, many dollars that are important to our country. And so I'd like to see it drive a little more leadership and a little more direction to get some of these standards. We don't need to make up a bunch of standards. Heavens, we got so many standards, we don't know what to do with it. We need to go determine the appropriate ones that we're going to drive. I mean, might it be better today because of what we could make our vehicles a different size to have 3 lanes or 8 lanes and we can go all different directions? Maybe we want to sit back and go down and do that math Maybe today there is better technology to do it, but why? We got the right side and the left side and it works. I mean, I would say we have enough standards to get this liquidity in place if we would just decide it's time to do it.
I think I heard a little bit of, I think Karen, I don't want to channel Karen, even though we do go back to high school, but I did hear from her a sense that, that she agrees with that. You need standards, at least for these key data elements, but also some nervousness about stepping in too hard as the government and coming up with these. In many other areas of where standards are needed, government mandate may not be required if everybody in the industry is really motivated enough to come together behind something. If you were Karen, is the best approach here to push harder on these key standards, or is it to push harder on creating the business case for people wanting to use them?
I heard two things today I heard a lot of things today that I thought were really interesting. One was an attitude of, do we really want the government to to create another $10,000 toilet or a $50,000 hammer? And part of it is that's self-fulfilling in many instances. We can do it. We have really smart people at ONC, at NIST, across the government. And if it was to get coordinated and worked, appropriately led, I think we have the right people to get the job done. And so the second thing I heard was a little bit of a lack of courage. We have to have the courage to do it. Do we know the answer? Do we have enough smart people? And then drive that into our country. And I think if we had those things, we could have this done much quicker than the approach that we're taking. What we're going to do is we're going to have another, this year alone, we'll have another 365 of these particular meetings, and we'll talk about it.
Well, this one's really special.
Yeah, but this one's a special one. So there'll only be like 362 like this one. No, but we need the leadership and we need to get action because I think we know the answers at this point.
But I also think it's, going back, we have been pursuing the right standard for a long time. I mean, so I go back to when we started ONC in 2005.
That's where ONC started.
I mean,
let's get the standards.
David and I always said the best thing about health IT standards is there's always one around when you need one. I mean, there were 128 entities that came through the office that said, I got the standard for you. Just bless this one, anoint this one, and we're done, right? And I think that's a problem, right, if we try to do it that way. And so we tried to bring together all 128 in a room, buy the coffee and donuts, and say, you don't come out until you come out with some meaningful standards. And we were soundly criticized that the ones that they came out with weren't usable.
Or you got 10 more.
Or there was something else needed. So I'm not, I agree with Mark that we are not going fast enough. I'm not sure how to hit the accelerator to get it done. Maybe it is, in fact, have the courage to say, all right, we've had enough discussion. Let's take some action on all the discussion we've had. It does seem like we've talked about standards for a very, very long time, and we do need to do it. We all do appreciate the value of a standard. I mean, Mark and I were talking last night. One emperor's decision about the width of the axle did, in fact, set the road width, the bridge width, the Grand Canal width, because the boats had to be so wide. All that got propagated out of one decision. Health IT could be very similar with probably more than one decision on the standard, but a small set. Doesn't have to be 1,000 standards have to be set up, but there could be a great value and a great advancement done if we could agree on how we're going to communicate with one another, how we're going to make this computable. That's the other part of this, is to make sure that we talk about machine usable standards, not human usable. We as humans do a tremendous amount of integrating that we kind of take for granted. We can take in white blood cell count being reported as cc's or milliliters or per high power field, and we just integrate that, whereas a machine can't do that. Right. So we've got to get it to the granularity that a machine can do this. And we certainly saw that in the Department of Defense when we were setting up our system, that is a problem between machine readable and human readable. So I don't know. I agree with the need for speed here, but I'm not sure I got a clear pathway for exactly how to get there.
Oh.
I've got an anecdote, but the caveat, the data elements are a lot simpler. So some years ago in London, my hometown, there was a very similar meeting around the bridges, because logistics companies didn't know when the bridges were up or down, which they needed to optimize their business models. So standards bodies spent a long time getting a lot of people around the table to try to figure it out. And guess what happened? Well, Twitter came around and gave each bridge a Twitter handle, open APIs, and all these third-party entities just integrated with that. And guess what? Problem solved. And yeah, the caveat was the data elements were a lot simpler. I think the analogy here is, and there's this stuff brewing, but it hasn't been announced. But again, this whole notion of what's the right consumer platform, which will get adoption. It wasn't the PHR as an example, but what are the right platforms where consumers will put their data on because it creates a lot of value? With the Apples, Googles, and a bunch of other companies now jumping into this, and there's one I can't talk about, but it's very fascinating because if they do get adoption and there's business models that work, again, the issue of interoperability is somewhat of a technology problem, but it can be solved with cash and talent, as long as the business model is problem solved. And then I think some of these policy issues will be solved along the way as adoption increases.
You all have highlighted business models as opposed to, or business cases as opposed to just use cases and kind of the technical side of this. I just want to go back to where we started with one last follow-up here on the interoperability standards, with Robert's emphasis on the many constraints on providers today between health IT, meaningful use, and quality reporting, and or caring about some other priorities like public health reporting. Has there been, in the development and implementation of these interoperability standards and in the roadmap, has there been enough attention paid to things that can just, not just improve quality, but maybe improve efficiency in the short term, so making it easier for doctors to get utilization review requirements met? I know that's one where I hear all the time from Peter and his colleagues that you can't just, that can't be handled just through the EHRs now. It's something that takes up a good deal of time and creates a good deal of physician and patient frustration. Are we thinking about the right key standards to focus on for interoperability? And this is to Mo's point. It does seem harder than the bridges in terms of a lot of data that could be standardized in terms of where to start to get the most bang for the buck and to make the most progress. Any final thoughts on that?
I think we talked a lot about standard. I want to just bring up, I guess, another dimension of this. Two things. One is the importance of the business process and the workflow. We often forget, we got talking about technology, but I'd say the technology is hard, but the business process and the workflow part is even harder. So we ought not forget about that. But now, putting on my CSE hat, one of the things that I think is happening over time here is that I've learned a lot about technology working at CSE and being the chief medical officer there, but it's my view now that electronic health, in every end of the industry except healthcare, one of the big aha moments for technology was the rolling out of an enterprise resource planning system, ERPs. These were the huge successes in manufacturing, retail, all that kind of stuff, where they pull data from multiple sources and do really cool things with it to help advance whatever the enterprise is. I think in healthcare, we've sort of accepted or expected the electronic health record to become the ERP for healthcare. That was the core piece of technology that was going to marvelously improve all of our healthcare systems. And the problem is, it became not just a medical record that we recorded our clinical findings to help us as physicians and our fellow workers in healthcare, but it became a vehicle for regulatory compliance, for financial billing, for strategic planning, for all these other jobs that got put on the electronic health record. And one of the frustrations for physicians is we're expected to feed that ERP system for a lot more than just the clinical data that we normally want to put in for our clinical reasons for the record. And so I think the future would be that the electronic record will start going back to its original job, which is to be a clinical record of findings and plans, and we'll build a layer that sits on top of the electronic record, where this new functionality that we're talking about for regulatory compliance, financial, analytics, and all of that will occur in that new layer, and it'll just be a data source for that new layer, instead of continuing to load more jobs onto the electronic health record. And that new layer, I think, is a technology that is possible, and it will, I think, improve our opportunities for interoperability, because then it'll be remote from the electronic record and all the reasons why it's built the way it is. And it'll become less important what the electronic record is. Because we've also seen in industry today that we're sort of where we were with the phone system when the cell phones first came out. AT&T couldn't call Sprint, Sprint couldn't call Verizon. There was all this lock-in. People wanted to make their network the biggest, and there wasn't interoperability as their first priority. Once they took the bold step to get interoperable, I would submit everybody's boat floated up much higher. We need to see the same thing in electronic records, where we stop fighting to see who can get a bigger network of customers. We need to get interoperability, and I think all of our boats will float much higher with that.
Thanks, Simone.
I'd like to maybe just add on. So the way that we've tried to describe it to folks is like layers of an onion, and I think that's how you just described it. That EHR should be that first layer of that onion. But then layered on top of it are other solutions like these quality improvement registries, so we can get to what Michael talked about this morning, providing that concierge type service to the physician to be able to look at those individual data elements in the EHR, but kind of like Excel where you can create pivot tables and be able to pivot that data to look at that total patient population. I think that's where we have a real opportunity here with that next layer of the onion.
I would like, so if you look at your agenda, it looks like this panel should close at 12:15. They've had a lot to say, and I really appreciate the discussion. I don't have much to say on top of what the panels have already contributed. So I'd like to spend a few minutes now, see if there are any further questions or comments from the audience. So over here and then up here. If you could wait for the microphone just for a second.
My name is Michael Drebin, and I've been an entrepreneur and an investor in startup healthcare IT companies. In terms of placing capital, we're trying to figure out, I think, increasingly the landscape that we're operating in, which seems to change every day. And one of the things that I look at in reflection of the panel here today is how do we look at somewhat of a bifurcated philosophy around the handling of the data, in that there's going to be, in some ways, irreconcilable conflict between the personalized health information, which needs to be increasingly, from a privacy perspective, secure and safe environment, and then the information that has the personal identifiers removed, which is infinitely valuable in terms of actionable information, and that's the future. And so the panel, what's your feeling on, how do you reconcile two very disparate philosophies and how you manage that implementation?
I'm happy to kind of take the first crack at it. So I talked about these layers of the onion. We can also think of them as concentric circles. That the core of it is that data from the EHR, that HIE. But as you start going out, adding on quality improvement registries, and then the outer layers of the circle are exactly what you're talking about, and that's the de-identified data for research purposes. And that's what the IOM has called for, is the learning health system, to be able to now take those learnings and bring it back. So I don't think of it as two separate agendas. I almost think of it as these circles that there's just continuous layers of it, and what information do we need in order to be able to do what we want to do in those outer layers, such as research.
And I guess I would just say that, to me, again, bringing my CSC hat in it, I think that there is a big need for us to talk a lot more about security in healthcare data. I mean, I think we heard it this morning. There are two groups, those that have been hacked and those that don't even know they've been hacked, right? But so I think that we're way behind in this area, and it's worth my mentioning that there's now criminal elements that are going after healthcare data. It used to be the nosy front desk clerk that wanted to know what Madonna's blood type was. That's a privacy issue. But now security is a big problem. And the street value of a health record, they say the Anthem breach brought this out, that the street value of a health record is 20 to 50 times the street value of a credit card. Well, if they're going to go through a thermostat to get to credit cards at Target, they're going to be working even harder to get to health data. And those of us in healthcare that are protecting that data, we need to bring in industrial strength techniques from other industries probably, to make sure we're using the best techniques possible to secure health data, because the criminal elements are way, way ahead of us in this arms race. And I just think we need to pay attention to that. It's not quite to the point about de-identified versus identified data. I agree that there are multiple uses for the information that are out there. I also believe that there are newer technologies that will help deal with some of this reuse of the information for multiple purposes.
So which industry should we bring it in? Retail? Oh, maybe not finance?
Well,
DOD?
yeah, so we're losing an example of what the gold standard is when major financial institutions are getting taken out too. But the same people that are going after those financial informations are coming after us. That's my point.
It was just being funny, not very funny. But
I spoke at the NSA last week, and so I asked them the same question. I said, what do we get out of the government three-letter organizations?
Challenging policy step. We are about out of time. Do you have a quick question, or is microphone over here?
My name is Li Yang, and thanks for your presentation. My quick question is, how are we going to solve the current healthcare system? For instance, allow the health services are really run by the staff or emergency staff or even accounting services. So the record may be, not only service is wrong, but record is also wrong. And not only just because of fraudulent billings, but and also because of the patient supposed to get the record, but the healthcare organization will not give. And then a customer complain, but step after step, they go nowhere. So I just wonder if you can get specific idea or how are you going to approach this type of problem. For instance, if you complain to the health organization, would that be just directly send a copy to the centralized area, then you can analyze from there and prevent further abuse?
Well, it is. I mean, it's a real. I mean, it has been a priority with the Blue Button Initiative. Ways of helping patients get access to their information has been something that HHS has emphasized. But there clearly are some gaps in getting that information, being able to use that information, making sure it's accurate. Any final thoughts on this important question?
Yeah, I mean, again, one of the things that I didn't mention in the 8 points that the AMA group came out with was, one is how do we use our new digital technology to better engage our patients? And I think this is a good example of where engaging our patients, there's a clear desire on their part to get more engaged in their healthcare, one for accuracy reasons, but just to have better information for them to make a better decision about how to take better care of themselves. And so we want to have a system, and well, really an ecosystem in health IT that will allow that engagement, not just on the clinician and administrative side, but on the patient side as well. And so whether it be to correct errors that are in your record, but more importantly, how do you use that information to engage more fully in taking care of yourself?
Last comment, I think, is a market opportunity. Athena helps providers get paid. You've got iHealth, which helps payers get paid. And now, again, with the shifting of risk, I've seen 2-3 companies which are essentially doing revenue cycle management for us as consumers. So they will make sure that our bills are coded in the right way, and they'll even go at risk with us.
All right. Well, lots of ground covered by this panel, both in terms of where we are, how we can get to a better, brighter future in terms of health IT supporting better care and more efficiencies and better outcomes in the healthcare system, and some steps for policies to take in getting there, including this shift in health IT policies away from general requirements and certification towards more practical support for interoperability, liquidity that actually has an impact on improving outcomes and lowering costs. So more to come on this. I do want to emphasize that this is an ongoing area of work for us at Brookings. Peter, Mo, others in this room have been collaborating with us and look for some further policy briefs and activities from us in this area. But as you've heard today, there is a tremendous amount of work going on to try to realize the promise of health IT, and a lot of reasons, a lot of challenges, a lot of very serious challenges around privacy and security, around true interoperability, around patient control and other issues, but some opportunities to move forward based on the ideas and perspectives and proposals that we've heard discussed today. Before we finish, I'd also like to acknowledge the ACO Learning Network, particularly our work group in the Brookings ACO Learning Network for effective use of health IT, for their support of today's event, and all of the providers who have been engaged in that to help bring out some of the issues that we talked about today. And a special thanks to the staff here at the Engelberg Center for Healthcare Reform: Chris Botts, Pratyusha Katakaneni, Michelle Shaljian, Joanna Klatzman, Ross White, and Marcela Cabello, but also especially Larry Kokott and Peter Bosch for some hard work in putting this together, our panelists for a great discussion just now, and all of you for participating with us. Thank you very much for joining us today.